it's actually very interesting to see the response from the participants. I think we still have a lot of work to do, because I see from one of the questions that ask about what is PBM all about, and I think a majority said that it's about managing donor blood. It's about donor blood management. It's not about the patient itself. Yeah. So we still have a long way to go. Yeah. We need to keep on educating all the clinicians out there. Yeah. As well as the healthcare providers. Yeah. So now we will open the floor to questions. You're free to actually open your video, unmute yourself, and ask a question. There was the first question to Dr. Lara, right? But I don't see it now. It's answered already. Can I ask that question, Dr. Lara?
Yeah.
There's a question that said, I've come across Jehovah's Witness who expressed that blood not in circulation is also not allowed to be given. There is blood from Cell Saver. It's about,
Well,
yeah.
Well, I would say that this is a very, very personal issue. It's a conscience issue. I think, yeah. But in order to maybe have this person reflect on that, I would say that we have blood in our body that is not under circulation. For example, blood which is in the spleen is not circulating through the vessels. So I think this notion can help this person provide an answer to this question. But I repeat, I think it's a personal issue, not a global issue.
Okay.
And actually, it's true that the blood in the Cell Saver is not circulating through the vessels of the patient, of course, but I mean, it's something that the patient has to decide for himself.
Thank you, Dr. Lara.
Can I add something to what Lara said?
Yes, Dr. Usoro.
So of course, maybe the person that asked the question knows it, but there are some circuits that also provide for continuity in the cell salvage, such that there is no break in the continuity. So such patients might decide that they want to go to centers that are using such circuits. But as Lara pointed out, we can also, not like forcing the patient, but we can explain to the patient the fact that actually blood gets sequestrated even inside the body. And I think there is somebody else who posted a chat that he wants to give an answer from the Association of Anaesthetists in the UK. That's David. I'm not taking over the role of the coordinator of the program. I'm just mentioning I saw a chat.
Yes, on this question, I think that
David Smith.
Is this, yeah, this Dr. David Smith. He wrote in the chat that on this question, I can offer a quote from the Association of Anaesthetists in the UK, if that would be useful. Yes, sure, Dr. David, please. Can you offer that quote?
Yeah, you can perhaps type in the chat box, perhaps, and then the rest of us also can see. Yeah, that will be good.
Or the host could unmute him if he's in the attendees section. Could go to the attendees section and put on his microphone.
Okay. David Smith, right?
Yes.
Yeah, so David, if you would like to comment, yeah, then
thank you. Can you hear me?
Yes.
Yes.
This is from the guidelines issued in July 2018 by the Association of Anaesthetists in Britain. an anesthesia and perioperative care for Jehovah's Witnesses and patients who refuse blood. And it was prepared by a group of anaesthetists, 2 Jehovah's Witness representatives, lawyers. So it's considered very authoritative in the UK. And this is what it says about cell salvage. In the case of cell salvage, the equipment can usually be set up as for non-Jehovah's Witness patients. That is, there is usually no requirement for a continuous connection from the patient to the cell salvage system and back to the patient. This is a new recommendation. However, some patients may request, as a matter of personal preference, some form of continuous connectivity. So I thought you might like to hear that, because that's in the public domain, and it's a view that was put down in this guideline after consideration by both clinicians, lawyers, and representatives of the Jehovah's Witness community.
Yes, thank you, Dr. David. Yep, that's, yep.
Thank you.
That's
But I'm
very
not a
useful,
doctor.
yep. Mhm.
Thank you.
That is indeed
There-
very useful
There was
to
also
know.
a request. Sorry, there was
Yeah.
also a request from David Smith, right, regarding the case, the clinical case of the patient with the aortic dissection.
Mhm.
David,
Yes, this is the question from David Smith for Dr. Oller. I lost the slides, and so yeah, he wanted to actually find out about the clinical scenario. Yes.
Yes, if that's okay, I can share the slides again. Just a second. Here. So there we are. Yes, this patient was a 65 years old female, diagnosed of aortic dissection type A that involved all aortic arc. Actually, the brachiocephalic trunk was affected. That's why she suffered loss of or weakness in the left arm. She was a Jehovah's Witness patient, and that's why she suffered a lot of pressure in the hospital where initially she was, and finally, given that she refused to be treated with blood transfusion, she was finally transferred to our center in helicopter. She was hemodynamically stable. This is the team, but she was hemodynamically stable. She arrived sedated and intubated. Her Glasgow before intubation was fine, only the weakness on the left arm that I noted before. Esmolol, she arrived with an infusion of esmolol, and her hemoglobin upon arrival was 11. As I said before, no acute normal volemic hemodilution was performed due to her low hemoglobin, and we applied the general protocol that we apply for every single patient. Hypothermia, 25 degrees of temperature were reached in order to tolerate the circulation arrest that lasted only 12 minutes. So this is a demonstration of the amazing work that the surgeon did. And well, after cardiopulmonary bypass, as an anesthesiologist, I try to apply normal volemic hypertension until surgical hemostasis was achieved. And after that, I initiated an infusion of noradrenaline for systolic blood pressure about 100 more or less. And of course, the coagulopathy was noted, and we treated that with human complex, fibrinogen, desmopressin, and tranexamic acid. And she finally, bleeding was controlled. And then she was transferred to the ICU, sedated, intubated with noradrenaline at a low dosage. And well, I don't know if you missed these slides. Well, we can continue. Her hemoglobin
that is very helpful. Thank you. Really
okay,
helpful.
that's fine. That's fine. Did
Thank you
I
very
answer your question? Okay, good. That's all.
That was a remarkable case, actually, right? So, yeah, because considering the case, you would expect a huge amount of blood loss. Yeah, but yeah, it's remarkable indeed. Yes. Thank you, Dr. Lara.
Thank you.
Yes, I think we have a
There are
couple of
questions.
questions too. So maybe one bit is it?
From
Yeah.
Dr. Tan. From Dr. Tan.
Yes, correct.
Can you read that? Mm-hmm.
Yeah, sure. So here it says, Dr. Tan actually asked, what is your transfusion threshold for patient undergoing SSG or flap surgery, as some surgeons still insist to keep HB 10 to 11 post-operatively despite no active bleed. So perhaps we can ask this maybe. Would Dr. Gapay, would you like to give some comments? And maybe I would like to call on Sherri after that. Thank you.
Well, PBM includes also post-operative strategies in maintaining, in improving patient outcomes. So after the flap surgery, we keep the surgeon, it says here, the surgeon still insists to keep hemoglobin 10 to 11 grams, despite no active bleed. But studies have shown that anemia, whether mild, moderate, or severe, can result in poor post-operative outcomes. So 10 to 11 grams of hemoglobin is anemia. So the surgeon is right to insist that the hemoglobin should be kept normal. 10 to 11 is still anemia. So as much as possible, it should go up to around 12 or 13. So I agree with the surgeon that even if there is no more active bleed, the anemia should be corrected.
Yeah.
Thank you.
Thank you, Dr. Gapay.
Yeah.
So it is true that we would need to correct anemia. However, it's quite interesting that, there is this dichotomy, right? So meaning that it's either anemia or transfusion. So the thing is, we would like to get some comments too from Sherri Ozawa, because she's been doing a lot of work on this area with regards to blood failure, as well as patient blood management. And we'd like to get some ideas from her. What do you say, Sherri? Are you in? Or if not Sherri, then perhaps we can. Yeah,
Hold on.
Sherri.
I apologize. Could you just repeat that question? I'm sorry.
Oh, no problem. Yeah, thanks.
Sorry.
So you see, right, from the question, actually, a lot of us might think that, something that is abnormal, right? So example, maybe anemia, HB of 9, 10, 11, or something like that. But the thing is, right, because we tend to look at it in the sense of transfusion threshold. So meaning, right, if we want to correct a number, then we would think that, okay, I should top up to a certain level. And that's the idea. But what do you think about this? Because I think from the questions, it seems like surgeons might insist to keep HB 10 to 11 post-op. But the idea of doing it is by transfusion. So yeah, what do you say about this?
So, yeah, and I'm sorry, I'm sorry if I was a little bit behind. I was trying to handle another call. So again, we said for years in the patient blood management and bloodless world, right, that please stop thinking about triggers, which is good. And I think in many places, people have stopped thinking about sort of a point at which patients, quote unquote, need to be transfused. And we said, well, start thinking in terms of thresholds, right? So that until a patient reaches a certain threshold, you don't even think about transfusion. And again, when we're talking about bloodless patients, right? We're never going to think of that, but we're trying to even move beyond that thinking and sort of stop the thinking to targets, about targets. So maybe, that's the next step, because we do hear that still from a lot of clinicians, many surgeons. I want to transfuse to a target of something, or my target. And again, we would say, hemoglobin levels do mean something. They're a measurement, right? But they're a concentration. And we know from non-invasive hemoglobin monitoring that there's, more variation in that hemoglobin level than we think there is at the microcirculatory level. So, overall, I would say we have to, as a larger community, be less focused on that number. And when we talk about the tolerance of anemia, it's really about us as providers, right? Tolerating the anemia. So if the patient's tolerating the anemia, we need to tolerate the anemia too. And really be looking more about, again, a patient-focused approach of what is the patient's problem, what are the patient's diseases, what are the patient's symptoms, what are the patient's signs, and an effort to correct those, and be much less concerned with the number. Of course, we don't ignore what the hemoglobin is, but we should migrate away from this thinking of either targets or triggers, and maybe even migrate away from this concept of thresholds, and really focus on the patient's issues.
Thank you very much.
you.
So, yeah, I think it mentions you are treating the disease, right? So there's multiple strategies, like maybe, if you want to improve the HB, perhaps use IV iron, erythropoietin, those kind of things, as opposed to putting a transfusion threshold, trying to bring it up to a certain number. Yeah. And
Exactly.
I think, yeah. And you did mention something about blood failure before, right? Could you just briefly tell us something maybe about blood failure? Yeah. Just
blood failure?
Yeah.
Yeah, so it's kind of a concept that we're trying to expand around the world, and around SABM and in the PBM community, which is really looking at the treatment of blood as the blood in the endothelium, right, as the body's liquid organ. And just as other organs fail, the blood can fail. So when organs fail, they fail at the cellular level. When the cells fail, the tissues fail. And when the tissues fail, the organ systems fail. And so, if you think about it, let's think about heart failure as an example, because, that's a very recognized term. And even to the public, we talk about heart health, right? So it's not just the failure of the organ, it's the health of the organ. So can we treat blood the same way? Can we treat blood as the liquid organ system with the same respect that we treat every organ system, with the concept that organ systems can fail? And we as clinicians, and we as humans, right, as citizens too, have the right and the obligation to try to keep our blood health as we would keep our heart health. And if we think about blood failing as an organ that fails, how do we treat an organ that fails? Right? If a patient's entering into heart failure for whatever reason, it might be many reasons, right, that a patient might have heart failure, but we do all the different things to try to mitigate the effects of that heart failure. So we might recommend dietary changes to a patient, lifestyle changes, medication. They may need some kind of a invasive procedure. But when all of those things have failed, we've exhausted every possible option, then perhaps, and not for everyone, right? Perhaps for some patients, we talk about replacement of that organ, right? And because there's been a failure of every other therapy to really bring the patient back to a better living state. So if we treat blood mentally, if some patients, a transfusion is never going to be an option, right? But even for patients where it is an option, if we really treated their blood as this liquid organ, their own blood as this precious liquid organ, we would very, very rarely or infrequently turn to replacing that organ until everything else has failed. And really, we should be thinking as clinicians about blood health, right, as the opposite side of the coin of blood failure. It's our obligation to keep our patients' blood healthy, just as we would their other organ systems. So that really addresses sort of this anemia that's so common, and we heard it today. We'll hear it all the time. 2 billion or 3 billion people around the world are dealing with anemia. How many with iron deficiency? that's blood health. And if we think about that and bring it to the forward in the minds of both clinicians and the public, it changes our thinking about it completely, I think.
If I may add something, please, Ananthi.
Yes,
We must
Usoro.
take very seriously. We have to take very seriously what Sherri said about transfusion. It's actually an organ transplant. If we do a donor transfusion. Now, how many of us clinicians would do an organ transplant like kidney, liver, without HLA antigens being checked? What is HLA? Human leukocyte antigen. So if we're checking for human leukocyte antigen when we're doing kidney transplant to make sure it's compatible, then we pour everything in a blood transfusion without checking. It really doesn't make sense, right? So we want to understand that it's not really scientific. So even if a patient doesn't mind having a blood transfusion or doesn't know better, it is our duty as clinicians to give the best care. The patient who doesn't decline blood transfusion also has a right to a better outcome. And as I noted in my comment, the lower the hemoglobin is, the more important it is to avoid blood transfusion. We had a patient in my center, hemoglobin 1.3. I challenge anybody to tell me how in my center in Nigeria we could have saved that patient with blood transfusion. That would have been massive blood transfusion. And definitely the patient is likely to have died from complications. We cannot handle that. But the only way we could save that patient's life, and we did, was by using bloodless techniques and ensuring that the tissue actually gets perfused, which it wouldn't be if we gave the kind of blood that is available here. We only have whole blood. And of course, you know, our power keeps going off. So whatever you put in there, you're not sure that what is going on. Maybe it's even stale blood. So, but even if we have a good functioning electricity and the blood is well preserved, it has storage lesions. And if you're pouring a lot of that into someone with hemoglobin of 1.3, that patient is not likely to survive. But like I said, this patient survived because we use bloodless techniques.
Right, thank you very much, you both. And I think Dr. Gapay wanted to add on some comments as well. Please go ahead. Yes.
Actually, I might have been misconstrued. I might be misconstrued when I said that the hemoglobin has to be brought up. But in as I went to see the question again, it said transfusion trigger. So I did not mean that it should be brought up using blood transfusion. It should be optimized with the use of IV iron and other ingredients to produce blood. Now, but it has to be individualized. So in the question, we don't know if the patient has cardiac problems or patient has cerebrovascular problems. So the treatment should be individualized. And for instance, in patients with cancer, improvement in the quality of life, less fatigue, will be seen if the patient's hemoglobin is optimized to the normal levels. So individualized management according to patient's needs. Thank you.
Thank you very much. Yes, rightly said. So basically, you're looking at the patient, not a specific number. And so each patient is different, right? So we would like to also invite our another two anaesthetists, Dr. Kathiresan, and also, we have three anaesthetists some more, Dr. Kathiresan and Prof. Queeneth Kalu, and also Dr. Jonghyeon Lee. So maybe we get some information from you. Dr. Kathiresan, I think for some years, since quite a number of years, right, you had a number of experience in actually managing patients.
First of all, thank you very much for inviting me. And myself, initially I was working with the General Hospital, Kuala Lumpur. Then when IJN started, National Heart Institute, I joined there. When I we went to National Heart Institute. We started operating on the Jogawa's witness. From that time onwards till now, we have done many cases of Jogawa's witness without cardiac surgery. I do only purely cardiothoracic. I don't do any other case. There are a few things I want to highlight. You are just now, people were telling what is the optimum hemoglobin level. I attended a workshop in Society of Cardiovascular Anesthesiology. I'm a member of the Society of Cardiovascular Anesthesiologists, US. There was a workshop on the bleeding and coagulation workshop. They said you can accept up to 7 grams. Then you can build it up. No need to do give blood transfusion. That's what this one. But depending on the individual case, but we can, if the patient accepting blood transfusion, we can give. Like Jehovah's Witness, we cannot give, we can accept lower. And in our center, what is my practice, right from the pre-op, we have to take care, make sure they are not on the Chinese medication in our country. Most of the Chinese medications are antiplatelets for the heart. So we have to be very careful. Second thing, the multivitamins, some of the multivitamins have ginseng inside. So the ginseng also works like an antiplatelet. So you must be very careful. We have to stop that, like stopping the antiplatelets. Another thing is some of the people for cholesterol lowering, they take the ginger and garlic. This ginger and garlic also make you bleed. I had a very bad experience with one patient. I normally ask you, do you take Chinese medication? No. Are you on any ginseng part of the multivites? No, we don't take any multivite of that. I forgot to ask the garlic and ginger. The patient was bleeding and bleeding. This is not a Jogawa's witness. Other patient. So we rule out it is not a surgical bleed. We had to open up the case. We opened up. There is no surgical bleed. It's oozing everywhere. Medical bleed. Finally, I asked the patient's relatives, what is he taking? Anything else? Yeah, he regularly takes for many years ginger and garlic. It makes you bleed. So that is another lesson you have to learn. That is a pre-op. So intra-op, as Dr. Lara said, I do give tranexamic acid 2 grams after the induction. Then after the protamine, I do give another 1 gram of tranexamic acid. I give 1 gram of tranexamic acid in the heart-lung machine, the oxygenator. And oxygenator, we have a priming volume. It average about 1,400 to 1,800 ml of priming volume. That is the crystalloids. That dilutes the blood. So the hematocrit level can drop approximately about 30 to 35%. So for Jogawa's witness, what I do, I put a hemo filter in the circuit, heart-lung machine circuit. So at the end of the operation, what I do, normally we have to reverse the heparin with the protamine for the heart-lung machine. Because we give heparin high dose, we don't want the blood to clot in the heart-lung machine. So after the surgery over, we have to reverse it with protamine. So the venous line will be taken out. After the venous line is taken out, we don't give the protamine, we hold on. And then I filter the blood. If we empty the blood into the oxygenator, and then all the blood, whatever the line, the blood is in the venous line comes to the oxygenator, I filter it out, I concentrate and transfuse back through the aortic cannula is still there. Then I start the protamine is going in slowly, then protamine completed. I take out with the surgeon take out the aortic cannula. So I don't waste any blood in the oxygenator. So we filter and transfuse back everything. Post-op, we accept a bit lower hemoglobin for the Jogawa's cases. Normally, when I bring back the patient, they come out with about 9 or 10. Some of them drop to about 8. I have done many, they don't drop below 9 or 10. Some of them do drop to 8, 7, 6. One patient, not a coronary artery surgery, it was a mitral valve replacement, Indonesian patient. She dropped to 4.5 I think just now the Dr. Usoro just told it is 1.5 was 2.5 was telling. My patient was 4.5, and then patient was oozing. The problem is not antiplatelets. It is the liver. There was a tight metal stenosis. The liver was enlarged, and then congested liver. Then we had to give a lot of vitamin K, and we can't give any Jehovah's Witness. They don't accept any blood products also, FFB and other things. So we didn't give anything. Then slowly the bleeding stopped. 4.5. Then I started on Sangobion. Sangobion, you know that it has all the things necessary for the RBC production. It has the ferrous glumerate, 250 milligram. It has the folic acid, is 1 milligram. Vitamin B12 it has 7.5 milligram. Vitamin C, it helps to absorb the iron from the stomach. 50 milligram vitamin C it has. Sorbitol. Sorbitol, actually 25 milligram it has. It helps to prevent the constipation. Normally the iron causes constipation. So the sorbitol prevents the constipation. So I give Sangobion. Slowly the thing came up. So this is how I manage my job. As so many years, everything went smoothly. God willing, I think I can manage a Jehovah's Witness without blood transfusion. Thank you.
Thank you very much, Dr. Kathiresan. So yes, many years of experience, and so it shows that it can be done, and likely also it is actually beneficial to be done in many other patients as well. I think Dr. Jameela too wanted to mention something, and yeah, would you like to say something, Dr. Jameela?
Yeah, I think this thing about anemia, I think most clinicians take it quite lightly, I think, and they think that, anemia is, an easy thing. You can just transfuse and you can correct it. And I think we need to move away from this concept of, correcting anemia with a blood transfusion. So anemia is actually, it is managing anemia is actually very challenging. And I think we as clinicians, I think we should actually look into that area and not take the so-called easy way out, and thinking that it actually can just bring up the hemoglobin. But on the other hand, it may cause a lot of problems and complications. So I think we need to look into managing anemia much more appropriately. I think
Thank you.
Yeah.
We maybe can get a couple of comments, perhaps from liver surgeon, Dr. Shunji Kawamoto. And because liver surgery has plenty of bleeding risks, right? So how do you actually manage this, Dr. Kawamoto?
Thank you very much for inviting me in this excellent meeting tonight. Yes, I'm very impressed with the presentation you three doctors showed about how they're coping with the big challenge for the patient to limit the blood transfusion. And I'm one of the person who are treating the patient who declined blood transfusion, suffering the cancer of abdominal field, including esophageal cancer. And because I treat over 500 patients with Jehovah's Witnesses bearing the cancer, and especially we were still struggling to keep the patient stable condition in the post-operative state after the hepatic, biliary, the pancreatic surgery, because this field imposed many much invasive and much blood loss intraoperatively. So I also take into account the three parts of the pillar, which you already mentioned in the presentation tonight, because the preoperative anemia surely influence how to make a decision as how to build a strategy as to the procedure. Because with anemic condition, we can't do the aggressive surgery, of course, and we have to change our treatment for patients. But with the preoperative blood augmentation can certainly help us to embark on such aggressive surgery. And of course, the preserving the patient's blood intraoperatively is of paramount importance for all of us. However, in the postoperative condition, we are very concerned about the patient's systemic condition. So we can just analyze how the patient is going on from the data of hemoglobin. But we are very curious about what else findings except for hemoglobin is teaching us in the patient's condition. So in today's presentation, Dr. Lara shows the many other significant signs apart from the hemoglobin, such as lactate or base excess or the other tissue condition. So we need to analyze that findings along with searching the hemoglobin level. So I very want to know what else we can search the findings postoperatively except for hemoglobin to keep the patient's condition stable. Because we cannot take any blood transfusion for the patients. So to keep the patient stable condition, what else can we focus on as findings in the practice or some other test? So yes, I'm very happy to know how you answer to this question.
Thank you, Dr. Kawamoto. Was that question directed to Dr. Lara? Is that right?
Yeah.
Yes. So, Dr. Lara, would you like to say something?
You're muted, yeah.
Just a second. I could not hear clearly. Can you repeat the question, please, Doctor?
Mm-hmm. So besides hemoglobin level, what is the sign or findings you can focus on to keep the patient's condition stable?
Well, I think we will all agree that having a patient hemodynamically stable does not depend on the number of hemoglobin. It depends on the neurological status, blood pressure, heart rate, lactate levels, acid-base status, and urine output. We've been taught like this. This is what describes a patient who is hemodynamically stable. You can have a patient with a hemoglobin of 5, which is hemodynamically stable. You can have a patient with a hemoglobin of 12 that is clearly unstable. So hemoglobin cannot guide the decision whether a patient is unstable or not. We have clinical parameters that can help us guide the treatment of the patient, but not hemoglobin, not at all. Especially when we know that the hemoglobin at the capillary level is extremely different from that in the macrocirculatory level. And really, the miracle of life, as Dr. Shander always says, happens in the microcirculation. So I think we have to change our mindset and stop focusing on the on a number, on a concentration, which also depends on if you've done diuretics to that patient or not. I mean, it's something that cannot continue to guide our daily practice.
Yeah, there is some articles where Dr. Shander and Dr. Carson shows about the irreversible point of hemoglobin level. Below that point, a patient cannot survive. Yes, it's a very interesting paper. Because, yes, because as one of the process of treating the Jehovah's Witness patient, we cannot add any blood transfusion. So what is, I'm very, yes, curious about the OxyLife you're developing and searching how that sort of fluid can play a role to recover or improve the macrocirculatory status. And that how can we pick up the findings after that treatment? So is there any and some effective parameter to follow?
Well, I think you're referring to articles talking about critical hemoglobin. And of course, we know that there's a critical point where if hemoglobin continues to decrease, oxygen delivery to tissues is at stake. But in the paper we recently published in Anesthesia, we proposed a very interesting, I think, hypothesis, because we cannot forget that hemoglobin also represents viscosity. So viscosity, as I said, is extremely important in order to generate nitric oxide, which is a vasodilator gas at the capillary level that could help to maintain the capillaries opened. So we hypothesize whether hemoglobin, the critical hemoglobin, could have been or could be a confounding factor, because it is both a representation of arterial oxygen carrying capacity and also blood viscosity. How can OxyLife improve that situation? Well, OxyLife is a novel intravenous fluid that we are developing right now, and it has a triple effect. First of all, it increases the dissolved oxygen in blood plasma, so we may be able to sustain oxygen delivery to tissues even though critical hemoglobin has been reached. This as what refers to arterial oxygen carrying capacity. When it comes to the importance of viscosity for maintaining capillaries opened, OxyLife also contains trace amounts or a small dosage of nitrites and nitrates that, thanks to the nitrite-nitrate nitric oxide pathway, which is activated in hypoxic tissues, these ions can generate nitric oxide. That this could help to maintain capillaries opened, even though viscosity is decreased. And last, also OxyLife can the potential to attenuate ischemia reperfusion injury, oxidation, and preserve the glycocalyx. The glycocalyx is extremely important to maintain microvascular homeostasis. It really helps a lot in maintaining the fluid where it has to be. In the intravascular stream and avoiding excessive interstitial edema. So yes, Oxalife may be the solution for some of these patients that reach critical hemoglobin and they continue to refuse blood transfusion. Hopefully in some months, in upcoming months or years, we will be able to share more information on that. At this point, this is all I can say.
Thank you very much.
You're very welcome.
Thank you very much, you both. Yeah, that was an interesting discussion. And it is true that it's kind of a very balanced, right? A fine balance to actually determine, what is when to actually intervene and what to intervene with. I think we have, I think there was a comment from Dr. Sivananda Raja mentioning that we can also look at CRT, lactate skin temperature, and SCVO2. So yeah, it's related to the discussion as well that I would like to actually call on also Dr. Queeneth Kalu and perhaps get some insights from her. Thank you very much for joining. And she's a very strong advocate of PBM. Yes.
Thank you. Thank you very much for the excellent presentations. I have learned a lot from the two presenters. I just want to comment on the split skin thickness graft. I think the concern of that surgeon is about the graft taking or otherwise, because, and to my mind, that's an elective procedure. And back in the days of training as a resident in anesthesiology, we were taught that anesthesia is like flying an airplane. So you always plan for landing before you take off. And this is so true in elective procedures. So if you have a patient coming for an elective procedure, we really don't need to take anemic patients for surgery. So as much as possible, when the patient presents preoperatively, anemia is a good reason to postpone elective surgery. And that is a time we really have to optimize the patient and make sure that the patient coming for surgery is not coming in with anemia. And once that is done, the issue of the target hemoglobin postoperatively being lower than what would be required for the graft to take will not arise. And especially in our own environment, where the interesting presentation by Lara, some of the options you have are not commonplace where we practice. So we cannot readily lay our hands on some of the things that you have talked about. Of course, in this case, we are talking about red blood cells. In your case, you were talking about if you get into coagulopathies and all of that, you have options of coagulation concentrates and fibrinogen and the rest of them, which we don't have. And as Dr. Usoro pointed out, much of our transfusions, when we do it, is whole blood. So for us especially, we always try to ensure that those patients that we are expecting a lot of bleeding are optimized preoperatively. And that is the reason why some anesthesiologists, after reviewing the patient, would decide that the patient is not suitable for surgery, because you don't want to be forced to transfuse the patient. And then again, we are in a malaria endemic region. So anemia is very common, more common in our environment than it is, I believe, where you practice. That will be my contribution. Thank you very much.
Thank you very much, Dr. Queeneth Kalu. Yes, that is a very great insight indeed, because I like the point that you say you really have to prepare first before you start, right, the flight. Yeah. And we have a couple more panelists. I think we would like to ask Dr. Innocent what is his comment. I think he's a all-rounder, right? So yeah, how do you actually manage your patients in relation to intra-op? And yes.
I would like us to recognize that transfusion is not what we think it is. In times past, we used to say that to improve oxygenation, we should transfuse. Current scientific thinking is that it is the reverse. Transfusion decreases perfusion. So we should, for example, we are talking about anemia and wound healing, for example. Any surgeon who has operated on a chronically anemic patient will recognize that collateral vessels have opened up. So what that means is that anemia in itself would open up vessels that ordinarily were closed when the patient wasn't anemic. So the idea of being
Lost.
Is your connect? Yeah. So Dr. Innocent, sorry. Perhaps we will just
the HB of 4 percentage of hello.
Yeah.
Yes. Now we hear you. Okay, I think we lost him for a while. So maybe I can get a comment from Dr. Jonghyeon Lee while waiting for Dr. Innocent. Oh yeah.
I think I'm back.
Yes, you are.
Okay. So packed cell volume or hemoglobin is a percentage. How are you sure that the percentage of cellular component of blood is actually active cellular component? Do we have a way of assessing the viability of the cells that are being transfused? Are they dead cells? Are they about to die? Or are they really doing what they're supposed to do? For many who have transfused, they realize that transfusion does worse. In oncology, for example, transfusion is known to to worsen surgical outcomes, to worsen, to increase tumor recurrence. So the idea that we see blood as the magical fluid to solve the problem, we need to look at that. We need to actually look at what harm is blood causing to this patient. If a patient's hemoglobin is 4 and I'm to give blood, what harm is that blood going to cause? Let us recognize that we're working with two evils, anemia and the ills of transfusion. We must be able to weigh the two of them and recognize that transfusing may be worse than treating the patient without transfusing. That's maybe because I run a wholly bloodless center. So I do, in my center, we do orthopedics, we do OBGYN, we do oncology, we do across board. And patients come because they are anemic. And we take advantage of the anemia because anemia actually improves microcirculation. There are no red blood cells struggling for space to clog the area. And I'm sure in critical care, it's unless there are comorbidities, you cannot transfuse a patient with a HB of 7 in the ICU. That's current thinking in critical care because they have recognized the advantage of moderate anemia in recovery. So what one does is to use these improved understanding of the human physiology and oxygen delivery and oxygen utilization to advantage, so we don't expose our patients to the many deleterious effects of allogenic transfusion.
Thank you very much, Dr. Innocent. And yeah, it's quite interesting to get the insights, as well as perhaps maybe one last panelist, maybe we can get from Dr. Jonghyeon Lee. He's from Korea, and he has done also plenty of surgeries as an anesthetist, right? So he has managed cases. So would we get some comments from you?
Okay, thank you for inviting me. I'm very happy to be here. I also thank you, Dr. Lara's presentation. I'm very impressed. I'm also cardiac anesthesiologist. You mentioned bloodless aortic dissection operation, very challenging, you know. Our center is also bloodless center and PBM center implemented almost 35 years ago. Your protocol is very similar our center's protocol, but our center is also have another protocol for we use the strategy to reduce the amount of CPB, cardiopulmonary bypass. So we can reduce CPB volume in children. CPB is 120 millimeter. In adult cases, 500 cc. Also, we use the retrograde autograde priming, RAP of CPB. What's your opinion, your protocol?
Yes, absolutely. We also apply these techniques in order to avoid excessive dilution of the patient. But since this is something that is performed by the perfusionist, I didn't mention that during my presentation. But of course, as I said, you can try to avoid blood loss, but if the perfusionist is not in the same page, nothing can be done. So absolutely, I agree with you. We also apply these techniques, RAP technique, and other measures in order to decrease dilution of the patient during cardiopulmonary pump bypass.
Okay, thank you.
Thank you.
All right. Yeah, thank you all. And thank you, Dr. Lee. And definitely we have plenty of experience from all our panelists, as well as we really thank you, the participants. Perhaps we just want to show one last slide, upcoming events. Perhaps we'll get our Zoom host to perhaps show that slide. Thank you very much, everybody. And I'll, after this, pass back to Dr. Jameela to close. Yeah. Just show you the upcoming events. Sorry about this announcement. We will send the link to the participants later. And the next slide is upcoming events. Next one, please. Yep. And the next, yeah, correct. So there's the SABM Patient Blood Management Awareness Week coming up in November 1 to 5, as well as the Blood Medicine and Surgery Society. They have the conference on November 3 to 5, and ASPBM on December 11. So we have representatives from all of these societies today. So we hope that you all would actually like to join and learn together. Right, so I'll pass back to Dr. Jameela. Thank you so much.
Yeah. Thank you, Ananti, for taking all the questions, and thank you, panelists, for answering all the difficult questions. I think, I'm sure you all agree that this has been a very interesting webinar. Yeah, I've learned so much, actually. It's always good, to sit down and There are a lot of things that we can learn, and I hope that we can put it to practice, and change the way how we manage our patients, by practicing patient blood management. I think by doing it, I think then we'll become more confident in managing our patients. Initially, when we started with patient blood management, we also we were quite, actually we were quite afraid, because we always thought that, especially in dealing with anemia. But once we gain experience, I think we get more confident. So I hope that you all put all what you learned into practice. And I'd like to thank all the speakers, Lara, Usoro, Dr. Pao, and all the panelists for taking your time off from your busy schedule in coming here to educate us and to talk about all your experience. Thank you so much. And we hope to meet you in the coming webinars that will be taking place in November and December. Thank you all. Have a good night, a good day. Bye-bye. Hope to see you again in person, actually.